Uh, Thank you all students. I am Dr. Mohammad Arifur Rahman on behalf of Department of Nuclear Cardiology is going to deliver a lecture on trace echocardiography. So what is trace echocardiography? Trace echocardiography is an effective method for the evaluation of myocardial ischemia and viability. By the examining the response of wall segments to trace. Trace echocardiography has two main applications: risk assessment in patients known to have ischemic heart disease, assessments of myocardial viability in patients known to have ISD. Accuracy of trace echocardiography in the detection of significant coronary artery disease is 80 to 90%. So it is superior to ETT. And otherwise, trace echocardiography is safe and economical. Mortality is very less. But the diagnostic accuracy of trace echo is highly dependent on the training and experience of the operator. So regarding the pathophysiology, exercise and pharmacological trace normally provoke a generalized increase of myocardial regional wall motion and thickening with an increment of ejection fraction mainly caused by a reduction of systolic dimensions. Regional systolic dysfunction is usually caused by coronary artery disease, but cardiomyopathies may also show regional variation in function. The following principles are applied when interpreting trace echo. During trace, reduction of wall motion implies that the segment is subtended by one or more flow-limiting coronary stenosis. During low-dose pharmacological trace, improvement of function in an impaired segment implies that the segment is viable, either stunned or hibernating. The presence of residual viable tissue is more common in hypokinetic than akinetic segments, least common in dyskinetic segments. So this is the ischemic cascade. We all know it. The time from the onset of ischemia and detection is very late because when onset of ischemia occurs, there is first of flow maldistribution of coronary myocardial circulation, then hypoperfusion, then diastolic dysfunction, then systolic dysfunction, then ECG change, then angina. Indication of trace echocardiography: risk assessment in patients with suspected ISD, resting ECG abnormality which precludes interpretation, like if there is LVB, LVH with ST segment depression, inconclusive exercise ECG, inability to reach target heart rate time during exercise due to immobility, coexisting lung disease. In this case, dobutamine trace echo is best. Coronary stenosis of uncertain functional significance at angiography. Assessment of patients after MI. Trace echo can help identify myocardial segments which are prone to ischemia and identify regions of viable but impaired myocardium after MI. Dobutamine trace echo is reasonably safe 5 days after MI. Indications of AC: assessment of myocardial viability. Improvement with low dose dobutamine, biphasic response, no improvement. These are the pattern. So what are the contraindications of trace echocardiography? This is acute MI, unstable angina, severe baseline hypertension, uncontrolled arrhythmias, mobile LV thrombus, severe aortic stenosis, HOCM, decompensated heart failure, acute pulmonary embolism or pulmonary infarct. So what are the stressors? So it is an echocardiography which is normally done after giving a patient some form of trace. So what are the trace? These are exercise, pharmacological trace agents, and atrial pacing. These are the current 3 tracers we applied during trace echocardiography. What are the methodology? It involves patient's preparation, some equipments, and performing the test. So what is the patient's preparation? Written consent, avoid heavy meal several hours before the test. Rate-limiting drugs like beta blockers should be stopped 3 to 5 half-lives. Standard connections for a 12-lead ECG. What are the equipments? Exercise echocardiographic machine with standard hemodynamic monitoring equipment is needed. Resuscitation equipments and defibrillator should be available for emergency crisis. Software for echocardiographic machine to gain digital images. And performing the test. Exercise stress echocardiography, it is usually done during treadmill or upright bicycle or supine bicycle. So this is the picture of a treadmill exercise echocardiography. And this is supine bicycle exercise echocardiography. And exercise stress test. Exercise test is performed over non-exercise stress because it is more closely reproduce daily activities. Images are to be obtained at peak exercise with bicycle ergometry while the patient continues to exercise. Sensitivity will be reduced if the images are not taken within 90 seconds after exercise. Approved indications to terminate exercise test. Target heart rate shift, severe angina, hypertensive response, hypotension, sustained VT, ataxia near syncope, cirrhosis, pallor, or ST elevation more than 1 millimeter in leads without the QFs. So these are the some advantages and disadvantages of the stress echocardiography. You know, there is treadmill, upright bicycle, supine bicycle, dopamine, dipyridamole, etc. Regarding the pharmacological stress echocardiography, it is usually done by dobutamine, and sometimes by arbutamine. Dipyridamole and adenosine is an alternative, but American Society of Echocardiography in 2007 has recommended dobutamine as the first-line agent for pharmacological stress echocardiography. So all you know, the dobutamine is a sympathomimetic drug which causes increased inotropic, increased chronotropic, and increased blood pressure. Plasma half-life is short, 2 to 3 minutes. Low-dose dopamine causes inotropic effects through cardiac alpha-1, beta-1 receptors, then causing increased contractility. Higher doses causes chronotropic effects through the cardiac beta-2 receptors. So contraindications for dobutamine, this is only one contraindication is ventricular arrhythmias. Dobutamine trace echo protocols. First of all, a rest echocardiography is done, which is called rest scan. Then the patient is infused with 5 microgram per kg per minute for 3 minutes with dobutamine. Then increase every 3 minutes to 10, 20, 30, 40 microgram per kg per minute. If 8% of the age-predicted maximum heart rate is not achieved at 40 microgram per kg per minute, then a 3-minute 50 microgram per kg per minute may be used with caution. If adequate chronotropic response to dobutamine does not occur, then injection atropine may be given, IV. So what are the side effects? Most serious side effect is arrhythmias, MI, cardiac arrest. And less serious are tremor, nervousness, marked hypotension. And we should be ready with the dobutamine when we give a patient for stress echocardiography, we give intravenous dobutamine. So we should be ready to control the side effects of the dobutamine. So some emergency medication may be needed in hands. To the effect of dobutamine may be reversed if angina or other severe side effects develops by the giving injection smolol over 1 minute or injection metoprolol over 2 to 5 minutes. So these are the emergency drugs we have to be in hand during giving the dobutamine stress echo. After giving the trace, we do an echocardiography to compare it with the rest scan or rest echocardiography to grade the regional wall motion abnormality. In normal patient, there will be no difference in the wall motion abnormality. If in the hypokinetic grade, there is marked reduction in myocardial motion and thickening. In akinetic phase, virtual absence of inward motion and thickening, and dyskinetic or paradoxical wall motion during systole. It is dyskinetic when there is paradoxical movement of the during systole. And interpretation, in normal people, the response of the dopamine of the myocardium is hyperkinetic movement. In ischemic myocardium, resting function may be normal. In low dose dopamine, it may be normal, but peak post-stress infarction, it may be abnormal. When an abnormal dopamine response occurs, then two things we should bear in mind. If there may be stenosis in the regional section, or the segment may be stunned, or the segment may be hibernating. There may be false positive and false negative trace echo. You know, every test has a chance of false positive and false negative. These are the section in which there may be false negative or false positive. If we give inadequate trace, if the patient is on anti-anginal treatment, there may be false negative result. Mild stenosis, poor image quality, and also it is dependent on the operator. And false impression usually occurs in case of operator and mechanical problem, as the poor echo, or there may be cardiomyopathies. These are the myocardial zone which are assessed systemically during the trace echo: 4-chamber, 2-chamber, long axis, base, mid, and apex. Sample pictures. These are the sample pictures during rest and during trace. Apical 2-chamber view, short axis view, parasternal long axis view. Thank you. So it is evident then trace echo is a modality of echo. Normally we done a rest echo in every patient, but to assess the myocardium, sometimes we have to done stress echo. And in nutshell, the trace echo is done with some tracers. These tracers are exercise or pharmacological trace, like the dopamine. Exercise trace echo is best because it might mix the normal activities of heart during exercise. But when a patient cannot do a trace echo by doing exercise, then we go for pharmacological trace echo, and dopamine is the gold standard for trace echo. Trace echo is sometimes a good question in the written exam, so you should follow the lecture, I think, for written purposes. But in practical life, trace echo is a daunting procedure, so it is not usually you cannot do it in a chamber. You should do it in a hospital-based examination hall. Thank you. Do you have any question? Hello?
Yes, sir.
Then go for question for 5 minutes. If you have no question, I can give it a conclusion to the lecture. So thank you all. I have there is no question, so thank you all. Okay, thank you.
Thank you, sir. Thank you very much, sir.
Okay.
For your nice and short